Hello, my name is Jeff Hauk from George Fox University, and I'm here to present the 50-50 lecture series where we discuss how performance and behavior change are 50% physical and 50% psychosocial. This is sponsored by the Beyond Biopsychosocial Learning platform at beyondbiopsychosocial.com. Today we're going to take a look at a paper by Dr. Mary Jung from the University of British Columbia in Vancouver titled Cardiorespiratory Fitness and Accelerometer Determined Physical Activity Following 1 Year of Free Living, High-Intensity Interval Training, and Moderate Intensity Continuous Training, a randomized trial. And we're lucky to have the author, Dr. Jung, here with us today, who started the Small Steps for Big Changes program. And pairing with her is a physical therapist, Dr. Mary Hastings from Washington University, who wrote a recent paper on advocating that physical therapists take on diabetes prevention as part of their care plans.
I'm Mary Hastings, and my background is quite a journey where I started in sports medicine, athletic training, went on to physical therapy school, and I've always enjoyed a variety. I'm just curious. I'm interested in learning and integrating different ideas. I started thinking about diabetes and foot care because I liked casting and removing cast and wound care. And then started my research interest as an adjunct to that, as a research physical therapist. One of my recent passions is the role of physical therapist in the integration of exercise and management of a chronic condition, and that we should be at the forefront of this. We have the background in health, disease, multi-system disease management, and that we are the perfect professionals to make a difference, help them manage their diabetes, their disabilities.
Okay, well, I would say thanks for having me, and a little bit about how I came here today is as training in kinesiology, actually, in my undergrad, and really led me to start wondering about exercise adherence. You know, what was taught was all about how to get people to come back, and it literally hasn't stopped from there. I did my master's, my PhD, and my postdoctoral training in health and exercise psychology, and that's led me to my position here at University of British Columbia. My passion is similar to Dr. Hastings. I've developed and tested the efficacy and effectiveness of diabetes prevention programs in my lab, the community lab, which is purposely as far away from campus as possible in a very accessible area. And that's where my passion is on
That makes sense. It really comes through in like all the different papers and stuff that you've got going on. It's like you're really trying to transfer it to everybody. I couldn't choose which paper because you have so many papers on this. It's amazing because you've got a really complex intervention called Small Steps for Big Changes, and there's so many different parts of it. And I'll just kind of talk about a little bit. You've got the app-based tracking. You've got the psychological component, the behavior change component. It's really well developed. And then you've also got all this HIIT versus this continuous exercise program. And so what we've chosen, like for you to start with anyway, is this HIIT versus, kind of continuous exercise. So to kind of help us understand what the results of this are and what's your kind of key things you'd like to communicate to everybody from that's clinical and in terms of prediabetes.
Right. Yes. So the context of the paper is that we wanted to help people who are at risk for type 2 diabetes. So we had 99 individuals who were very low active and experienced overweight or obesity. And we knew that exercise is one of the key components of diabetes prevention. The challenge, though, that everyone also knows, and clinicians are well aware of this, is that beginning an exercise program and even worse, sustaining that exercise program is really difficult for these people. And so the rationale for this 1 year long trial was to see, can we give people the self-regulatory skills that are required to adhere to exercise in a really short amount of time so that it is feasible. And then, can we follow them for up to a year afterwards and see if those self-regulatory skills essentially stuck with them? Like, did they help them in the long run? And were they still exercising a year after the program? It's gaining a lot of popularity in the general population, as well as athletes, etc. And we have this other component that's always prescribed when we look at physical activity guidelines. Yet, right now, it's not necessarily helping people be physically active with just that recommendation.
If you just had to summarize some of the key findings, like from this particular paper, like what are the takeaways for you?
Yeah, so I think the big takeaways are brief behavior change program can really help people last or stick with exercise. We found with wearable tracking technologies that people were still engaging in physical activity up to 12 months after we had just 7 sessions with them over a period of 2 weeks. So I think we demonstrated that we can improve people's self-regulation, and that can help them adhere to exercise. The other main takeaway is the big question, people always ask, is it hit or miss? Which one is better? Right. And to this one, we say, or I can say, that they're both great. They're absolutely both great. Yeah. HIIT, as everyone knows, requires less time. So we prescribed half of the time, right? We prescribed 75 minutes per week of HIIT or 150 minutes of moderate intensity continuous training. Both groups ended up much fitter. Their cardiorespiratory fitness was much better than 12 months ago when they started the study, but it wasn't different between the two groups. So yes, people in HIIT, although they did less, they did half the number of minutes of exercise. They were just as fit as people who did moderate intensity continuous training. I bring it back to the ultimate question: how do we help people adhere to exercise who possibly may need it most? We're trying to stave off chronic disease. What's going to help them? And to be honest, I think it's either a combination of both intervals and moderate intensity, or what we want people to do, as long as it's eliciting physiological benefits. There's probably no wrong type of exercise modality, but I really believe that we must provide them the self-regulatory skills to go alongside the exercise prescription if we want them to continue to do it.
So I love that. Could you have examples of people who are really obese or really, sedentary and then doing HIIT? And then if I was a clinician, what does that look like a little?
What HIIT looks like to them is walking quickly on a treadmill and then reducing the speed to a slow walk. That absolutely gets them to 80 to 90% heart rate max. And so if you can just envision that, and when we get people to go outside, it's walking up a hill, walking down a hill, and even the pace might not change, but it's the grade. And so we, confirm by accelerometry that they're in those heart rate zones with the heart rate monitor as well. And yeah, it's really fascinating to see. And one more thing before I hand it over to Dr. Hastings is what we often find with individuals with obesity is that knee and hip joints don't love to be walked on for excessive amounts of time. Yeah. And so actually, we were initially in our first pilot trial a little bit concerned about just discomfort. And as soon as people tried HIIT, they loved it because it meant that the number of repetitions on foot is significantly reduced, right? When you do a HIIT workout and we start them out at 4 intervals, right? You can be done in 10 minutes. That's kind to the knees.
Dr. Hastings, how does that sound adaptable, or you've had experiences working with people with diabetes instead of just pre-diabetes?
Well, it's interesting. I went and just did a HIIT trial, like a HIIT exercise protocol the other night, just so I could. And I think I might have done the super maximal effort. I don't think I prescribed myself the HIIT correctly. So I'm like, I'm kind of still recovering from my HIIT experience. So I got like a hit like that. But I was wondering, the app-based component of it versus the self-efficacy training or the behavioral training. I wonder what you thought about the contribution of each of those components to the outcome. And so I thought the app, of all the parts to it, seemed like to me one of those components that I thought would probably be most beneficial to people is accountability. I think is what that is checking in with somebody, being accountable for your behaviors, and then that human-ish contact with somebody else who's caring about you.
Within the app that we were using, it was two-way interaction. So, we could send out that message, but really the message within it was based on the self-regulatory skills that we had done in the counseling session. So when we talked about goal setting, then the message would be, hey, Jeff, you talked about setting the goal of da-da-da-da-da. How's that going this week? Or it looks like you're doing well on that, what have you. It's interesting how people use app technology. So sometimes, like you referred to, that accountability piece is there, but you can't always see it because sometimes they don't respond. But then when we do our exit interviews, and I love the app. Like it's like you didn't even use it, but it's that piece of checking in, right?
So I want to dovetail on Dr. Hastings' question. We oftentimes hear when we're doing behavior change kinds of things, we'll ask the patient, how can we support you? They'll say, I don't know, and then we'll say, well, what if we call you in a week and then ask you about, how these goals went? So many people want to be called and just to have a check-in, just some kind of accountability. And one of the things you did in the study was if somebody didn't do their app or something, in 3 days, then you initiated this call.
So, the systems for SMS now are so slick. They will just automate that for you. And now way back in the day when we were doing this RCT, I actually had an assistant would click the button so that we could personalize that message. But the message was already sent, and it said the same thing. If you hadn't checked in 3 days,
right,
just checking in, things going okay. We hope that you can get back on track, and then we would remind them of their follow-up session because we would have them come in for testing.
So do you have a sense whether that increased, then the next day, did they exercise, or did you see that?
Yeah. Yeah, so, and we published this in a separate paper by this PhD student I'm talking about, McPherson, and at our lab on the frequency of sending those text reminders, and does it help or does it not? Essentially, it helps until about 6 months. So if somebody was needing a check-in point, that reminder absolutely boosted their fitness, not just for the next 7 days, but for several months after that. So that helped. After 6 months, once we continued to send a reminder, then we got the drop-off effect as anticipated. If somebody's failing and it hasn't worked out for the first 6 months, those reminders can become nagging and not appreciated.
The social cognitive model is commonly used for behavior change interventions. The Small Steps program is a good example. This model focuses on the interaction of self-efficacy and value-based goals, where self-efficacy is defined as one's belief in their ability to overcome obstacles. As people believe in their ability, confidence improves and their goals become more achievable, and they define higher goals. This often results in positive lifestyle choices. However, several factors influence self-efficacy and value-based goals. Social structural factors, or what we might define today as social determinants of health, can influence self-efficacy and value-based goals. Examples might be lack of time or other obligations that interfere with engaging in a positive lifestyle choice, like exercise. So in this way, social structural factors can influence self-efficacy and goal setting. Another factor is outcomes expectations that can be physical, social, or self-evaluative. An example of a negative physical outcome expectation might be delayed onset muscle soreness. Positive expectations associated with social outcomes might be praise from others for exercise, or positive feelings of self-worth as an example of self-evaluative outcome. This model encourages behavior change by focusing on self-efficacy and value-based goals to achieve positive lifestyle choices.
What did you find about self-regulatory? You tested task self-regulatory efficacy and also, or task self-efficacy and then self-regulatory efficacy, right?
Yeah, I think what happened, and this is in the main paper that we published in 2020, is that self-regulatory efficacy and task self-efficacy, they both increased the same in both conditions.
I see.
I anticipated that we would bolster efficacy higher in the HIT group, and that's because every time you complete an interval, the coach or the trainer had the opportunity to say, "Way to go," and provide that sense of verbal mastery. But more importantly than that, the person, Dr. Hayes, after you complete a HIT workout, you're like, wow, I didn't just work out, I actually accomplished something big here, right?
Yeah.
And that we know is the strongest source of self-efficacy, that past performance accomplishment, that feeling of, I didn't just go out and do the same old. I actually challenged myself and I achieved that. That's quite powerful from an efficacy perspective. So what I was hypothesizing was that self-efficacy would be higher in the HIT group. Now, it didn't. With both groups had the same efficacy counseling and both groups had the same increase. What you will see in the next 6 months, we're just publishing the self-regulatory efficacy data, is that it actually mediated the relationship between which condition you were in and how physically active you were 12 months later.
So let's go now to your approach, right? Because basically you did the exercise instruction and then they exercised, but then you added
Small Steps adds 10 minutes to each exercise session, focusing on self-efficacy.
The Small Step program builds self-efficacy using 4 methods: verbal persuasion, vicarious experience, skill mastery, and emotional and physiologic state. Verbal persuasion is using persuasion to influence someone's beliefs and confidence. An example is positive encouragement for completing a home exercise program or some task in the Small Steps program. Vicarious experience is watching others succeed, and examples include group exercise or videos of successful participants. Skill mastery has to do with succeeding at a task, but it's important that the person overcomes obstacles in that success. And so advancing their HIT exercise program or going out when they don't feel like it and exercising are both examples of skill mastery. Then reading your emotional states correctly when you're exercising gives you confidence to participate because you feel safe and that you're at the right level of challenge.
You're right. It's the actual personal experience that's going to be the most potent effect on somebody's confidence in their abilities to do something again. So you can tell me till the cows come home that HIT's going to be great for me and it's not that bad. But until you do it yourself, you probably won't have confidence to do it. And so the first step was to get people just trying it. And so we're talking all about the physiological sensations. Does it feel like your heart's in your throat right now? Are your legs burning? Do they feel like you can't push any further? Yes? Okay, perfect. You're doing it right. And now we're going to go up and look, you're done your first interval. It was 1 minute long. You just succeeded. All you have to do is do that exact same thing again. And so that's all, in my view, physiology, right? The bigger pieces about efficacy that we really wanted to get people engaging in is their confidence to engage in exercise when there are barriers, when it's raining, when they're tired, when their kids are yelling and they just got home from work and da-da-da-da-da. So that's that self-regulatory efficacy, and the same rules apply. You only build your confidence by practicing it. So the homework we had people do was they'd come into the lab, do HIIT, and then go away. You have to try this on your own, or even moderate intensity continuous training. Try it on your own, come back to us in a day and tell us how it went. So the practice of overcoming those barriers is what bolsters people's confidence.
I have a question for you. I think physical therapists, do a lot of this kind of conversation without really realizing what we're doing. And I wondered if there's, let's say, great job. That's maybe what you would say, like, great job. You met this goal. Is that sufficient? Or are there ways to change your language to make your comments, your instructions more potent?
Yes, but I do think you can make it more potent by drilling into what the goals the client or the patient has set for themselves, and attacking that way. So sometimes great work can sound like, I'm the boss and I'm deciding whether you've done good enough or not. But if you say, Jeff, your effort on that looked amazing. Did you get 100% in there? Or, wow, Jeff, you said you wanted to go for 45 minutes and you did. How do you feel? And so it puts the, instead of I'm judging you, it puts it on to reflecting what their goal is.
Okay.
Well, as I was thinking about a lot of these in my experience with patients, so mine they have a chronic disease that is worsening. And so I was thinking about how you encourage people to do activity when what they see is not that they're better. They might just see that they're the same. And that is so discouraging, right? That your goal is just not to worsen. And how do you stay motivated when that's your goal near the last decade of your life with chronic disease? That's a really reasonable, incredible goal.
I love that question. Yeah. And so we do, like you mentioned, lots of the individuals that we get the opportunity to work with are focused on weight loss, right? They think that stave off disease, if they can lose 50 pounds, or that's the ticket. And that may happen, but there's, like you suggest, it's not motivating every week to, let's say, just weigh yourself if you don't see those changes. So we make sure that we provide measures of other things that we know will change. And so for people with prediabetes, we do measure HbA1c. That's, the gold standard. That's not a number that moves quickly. To move that needle, we focus on blood pressure. We focus on their resting heart rate, things that we know engaging in exercise regularly will move that needle a little bit. And yeah, we measure weight if people want us to, but we keep it back to like what things we know will change. And I think for people with type 2, so I'll be quick here, but I think with people with type 2, depending on age, right, we can see some movement in those pieces, depending on the frequency of exercise that they engage in. Of course, those who have the most to gain are starting from the lowest levels of fitness, such as, very common 6-minute walk test, or something like that, where they can see some tangible change.
So I want to jump in on this conversation too, because I think I did, when I was looking at your program and the autonomy part of what gets commitment in the social cognitive theory, the self-efficacy gives you confidence to progress, but what gives you commitment to follow through is that the goals are really connected to your own values in a way that's really important. So did you really kind of do this kind of value-based things that like a psychologist might do? Or
We definitely did. And I know it sounds like it can take a long time. So for those who are practicing, but it really doesn't. We tend to, to ask questions like, or in general, or certainly I know experienced healthcare practitioners, what brings you in today? If you rephrase that question to, or you can even start the same way, what brings you in? Oh, my foot, what have you. Okay, and why is that a problem for your everyday life? What does that take away from your life? And people can often tell you within seconds, literally, because the gut response is, this is so aggravating to me because I can't do my job, or I can't play with my grandkids, or I love my dog and I can't walk my dog. And so that takes you right into that person's values. And then when we goal set, we know from the famous Latham and Locke literature, personally set goals are so much more motivating than somebody assigning a goal from exterior. So then we can say, so what would be a goal that we can work on together that would help you get back to walking your dog each day? And then we can start talking about minutes or rehab components.
I would think what we're kind of talking about, especially with chronic disease where so much of their life feels out of their control, is finding something that they can control. And that might be a way to they might not be able to make huge gains in any of the measures that usually you see, but if you can give them control over something that's really important to them, that might be the framework of autonomy, or making the goal real for them.
So let's revisit the social cognitive theory. The direct influence of self-efficacy and negative outcomes expectations on a person's behavior we left out of the previous drawing. And here we can see it influencing how the person behaves separate from their value-based goals. Why that's important is because if a person's feeling a victim because of their disease state, they may have a discrepancy between value-based goals and their negative lifestyle choices. Reconnecting somebody with their value-based goals may get them back on track and give them a sense of control, such as Dr. Hastings was talking about. See myself, if I'm a person who is really kind of standing up and fighting this disease and I'm staving it off, then, my commitment to being that guy or that woman is really strong. And so I'm going to do things for that. But if my belief is I'm kind of victimized by the disease, right? And I'm just, there's no hope. One of the things that's been really impressing me when I talk to the psychologist is that value-based discussions. And so I wondered, like in this program, like the autonomy or goal setting part, what did that look like? And
but yeah, we definitely talked about values because that brings in, like you said, autonomy. And I also will say it also brings in that identity piece that you were kind of walking around. So if people identify as an exerciser, we know that they're more likely to be committed to it. And so we got to make them feel right, whatever that is. If that's buying the running room socks, or if it's, buying a headlamp because they walk their dog all the time and they're serious walkers, that's awesome. We should promote that.
I was kind of interested in relapse prevention.
Yeah.
That was one of the areas that I thought would be really useful for strategies because it sounds like after 6 months you're either in or you're out, or but there's some things you can do before that critical time frame.
And so I think the biggest thing is planning for that lapse. So in our work, in the first 2 weeks, we're talking to them about all this, and they're like, no, I'm on track, I'm on a roll, like this is addicting, this feeling, I'm so proud of myself, I'm never gonna stop. And it's like, no, you will get in a car accident, or you'll roll your ankle when you step over a curb, or something's gonna happen before we see you next, and so when that happens, then you set the date, and make it a realistic date. when maybe it's a month from when that incident occurs, but just put it in your planner and block it off and start with whatever's that small manageable step to get you back on.
Sorry, I just feel like it's giving people permission. Permission to just not be good at it all the time, and what good at it even means. I thought it was interesting in one of the two articles I read that I think the actograph probably isn't a precise enough measure to know what people were doing, but it seems like even the HIT people probably moved a little bit more to the continuous exercise activity, and who even cares, right? I mean, so I think giving people permission to, it doesn't matter exactly what you do, just get out and move around is better than not moving around. So I don't know, permissions I think is kind of the word that seems to me to come to mind.
Yeah, for sure. And the ultimate is when we empower people to be self-compassionate with themselves.
Right.
So,
Love that.
We're giving you, you shouldn't, don't look to us for approvals, but also, like relapse planning. It's, you got to be kind to yourself, because beating yourself over the head isn't very motivating. So giving yourself permission to, have a break, or like sometimes people would write in the app, well, I tried to do HIIT, but I went for a 2-hour hike instead, but it was really healing. So was that HIIT or not? And you're like, you went for a 2-hour hike. That's amazing. We don't care.
I love that one. So, I mean, one of the things I did in the other video, which I thought's interesting, if we just end with this maybe, is this idea of superpowers, right? And so what would you say though, because a lot of behaviorists, I mean, they have real opportunity to talk to many people with diabetes. So what would you say to them? Like if you had to give them something that would be something they could do like in a single session?
Honestly, it would be empathy. I would say it's not about you. And that would mean, I would want that information to get across as the person in front of you knows more about themselves than you ever will. So they actually are the experts in the room. And so once we give airtime to listen and reflect, and I think the right answers come.
That's perfect. That's like the best answer ever. And then Dr. Hastings, like if you had to ask for superpowers from Dr. Jung, like what do you want?
I would want a superpower of a team, right? So that you would, I know my part really well. I'm not sure I can take on the goals of and be really good at behavior change. So I always feel like, well, this is what I know. And I can go a little in your direction, but I can't be really good at what I know and really good at what you know. So collaborative healthcare, maybe that's what I'm talking about, is collaborative healthcare with the patient at the center. And I don't know that people are ever re-examined for, say, their knowledge of how to care for their diabetes. So like I'll ask people, they'll say, yes, I test my sugars every day. And I'm like, so what do you do when it's high or low? I just write it down. And I think, you don't have a plan? Like, did somebody, I'm sure somebody gave you a plan of what to do if it's high or low, or when to celebrate, but that it's good, a healthcare team that kind of pulls at all of these people's expertise to make the person be most independent and their healthcare be the optimal. Maybe that's a big ask. That's maybe like a multiple superpower ask.
I love it. Yeah, so you need money.
Well, I don't know. I mean, I think about how much money these folks spend on healthcare.
Yeah.
And how much of their time is lost in their independence, their ability to do their job. So I'm not confident it's more money. I think it's a concerted effort.
And I think then on respect too, right? So as long as, right, it's a collaborative team, I love that. If everyone comes to the table from different perspectives and each other knows the worth and the value of each other member of the team, I love that. I think that doesn't take money, and I think it would work.
I think that basically teams sharing superpowers and interdisciplinary training, really all of it is part of the solution to me. And it's like farm, like in this town, I'm living in a rural, countryside in Oregon, right? I mean, there's like nobody here. And so the pharmacist is a huge diabetes treatment person here.
Right.
And so working PT, pharm, and behavior, but behavior is like overwhelmed with PT trained but pharm delivered, or PT trained or behaviorist delivered, and then vice versa. Behaviorist trained but PT delivered, right? So it's like, I think it's not just a team, but it's also cross-pollinating skills that are transferable. And then that really kind of integrates the team. So it's like, hey, I was doing behavior change, but I ran into a wall. Come on, Jerry, she's our, behaviorist over here. Can you help me a little, right? And then you basically level up because it was an actual clinic situation, and then you saw that interaction, and now you're better. So anyway, I really love that, but I also think it's got to be really open in order for there to be a real change in primary care, basically. PT person's going to probably see people that are a little bit more, involved. That was what I'd say. So do you think would you recommend, kind of, because I think that we could do, more skills. Like one of the things I've been thinking is motivational interviewing with cognitive behavioral therapy. And so do you have an opinion about that, like those skills? Or
on what would I teach physical therapists to help them improve the relationship with their patients? And literally, just like you said, Jeff, I talked about motivational interviewing, and I talked about just 4 components within motivational interviewing. I think to become an expert in MI takes 20, 30 years, but we can take little bits, pieces here and here. So I talked about how do we ask open-ended questions? How do we provide reflective commentary and summarize what the patient's saying so that they really know that we're listening to them, not, okay, here's your RX and da, which I know most physical therapists wouldn't do.
What a great way to end. There's so many great points, and I'm so thankful for Dr. Hastings and Dr. Jung putting their full effort and really investing in explaining to us how the Small Steps for Big Changes program works, and Dr. Hastings reading the papers and really giving some great reflective commentary on how we might adapt this to people with more severe diabetes and prevention of diabetes in physical therapy. Thanks to both of you, and I look forward to reading more of your papers and implementing the Small Steps program in clinical care. Look for the Small Steps link below, the references from Dr. Hastings and Dr. Jung, and go to Beyond Biopsychosocial for more videos.